Thanks very much for the opportunities to present this work today at this meeting. It's a real pleasure to be able to speak to colleagues about what we've been doing. My name's Ramesh Nadarajah. I'm a British Heart Foundation Clinical Research Fellow based in LIDA, working under Professor Gale. And what I'm presenting today is this research project called Find AF, which is future innovations in novel detection of atrial fibrillation. And what we've done is leveraged machine learning within routinely collect electronic health records to try to predict atrial fibrillation. And really what I want to do today is just take you on a bit of a journey about how this project's developed and where we hope to go with it from now on. So I guess obviously the first question is the problem. Why are we looking at this problem? So obviously I'm sure that the audience includes clinicians, non-clinicians, etc. Atrial fibrillation is an abnormal heart rhythm, the most common sustained clinically significant abnormal heart rhythm in the world, with approximately 36 million cases diagnosed worldwide and between 1.3 and 1.4 million diagnosed in the United Kingdom. It's associated with a range of adverse outcomes: an increased risk of heart failure, an increased risk of dementia, an increased risk of death, and particularly it's associated with a 5-fold increased risk in the risk of stroke. And often strokes caused by atrial fibrillation, called cardioembolic strokes, related to small blood clots formed in the heart going off to the brain, are usually more likely to be lethal, more likely to cause severe disability. Unfortunately, though, huge pharmacological advancements over the last 20 years have provided us with a range of well-tolerated and safe oral anticoagulant tablets that reduce the risk of stroke from atrial fibrillation by about 2/3. There is an issue, though, that atrial fibrillation is probably going to be the 21st century cardiovascular epidemic. We've done some work using UK-based data where we've shown that the number of new cases diagnosed each year of atrial fibrillation has increased by 72% over the last 20 years. So there's actually now more new cases of atrial fibrillation diagnosed per year than the 4 most common causes of cancer combined. So that's lung, breast, bowel, and prostate cancer. And in spite of this huge number of cases that are diagnosed, it's estimated that about 30% of atrial fibrillation cases are currently undiagnosed. So 30% of the burden, it's estimated that about 15,000 strokes a year in the United Kingdom occur in the context of undiagnosed and untreated atrial fibrillation. And it's estimated that about 300,000 people in the UK are living with atrial fibrillation, undiagnosed and untreated, and thus at risk of adverse outcomes. And hence, the NHS long-term plan has early atrial fibrillation detection as a cardiovascular priority. I then moved on to describe that many people with atrial fibrillation are older and tend to have multiple comorbidities. And actually, the prognosis after diagnosis of atrial fibrillation is not particularly good. In fact, we've done some research recently that show that 20% of people within 1 year of diagnosis of atrial fibrillation have not survived. And as you can see from this figure in the bottom right, once you have a diagnosis of atrial fibrillation, your risk of a range of cardiovascular outcomes, renal outcomes, and death is adversely affected. And so the care of atrial fibrillation is not just oral anticoagulation, but it's better symptom control and management of comorbidities and risk factors. So effectively, the point I'm trying to make is that atrial fibrillation is common, atrial fibrillation is often undiagnosed, and atrial fibrillation is serious, that we need to try and diagnose it earlier so that we can optimize treatment earlier and improve prognosis and reduce the risk of stroke. So what are we doing in the NHS currently to try to diagnose atrial fibrillation? The NICE guidelines will show you that if you have symptoms consistent with atrial fibrillation, you have palpitations, breathlessness, chest pain, you may be diagnosed through routine investigations of those symptoms. There is an issue, though, for people who are asymptomatic, because for many people, atrial fibrillation causes minimal symptoms or is truly asymptomatic, but still causes an adverse risk of all the other outcomes I mentioned. So what do we do for those individuals? Well, the NHS England Innovation and Implementation Fund recommends that primary care healthcare professionals feel a patient's pulse, during a blood pressure check in the community to try to detect atrial fibrillation early, especially in the asymptomatic context. But many RCTs over recent years, the VITAL-AF study and D2AF, have shown that actually systematically using this system does not improve detection of atrial fibrillation compared to routine care. Also, people will have their pulse palpated at NHS health checks, but actually these are only for a circumscribed proportion of the population, and only about 40% of those who are eligible attend. There's been a number of research studies, randomized control trials, that have looked at more systematically investigating people with a higher intensity investigation. So providing people with a patch or a handheld recorder to actually see if they can detect atrial fibrillation by individuals checking their heart rhythm regularly. This has generally been aimed towards older populations and has been shown to increase rates of AF detection, but the yield of investigation is still relatively low, only about 3 to 4% of people who are investigated tend to have a diagnosis. And we also know that people in higher deprivation and minority ethnic groups are less likely to participate. And of course, if you're only targeting this to older people, you miss the cohort of people who are under the age of 65, who are at risk of atrial fibrillation and at risk of adverse outcomes, who tend to also be from lower socioeconomic deprivation groups, and therefore, and we've shown actually, tend to manifest atrial fibrillation earlier. So fundamentally, I would say that earlier identification of AF is important, but I would say that our current approach in the NHS are suboptimal to try to achieve this. So there's been a question about whether we should be screening for atrial fibrillation. So we know that for this graphic, that atrial fibrillation is very highly prevalent, including in the UK. But as I've said, trials that have looked at screening of atrial fibrillation have generally actually had pretty poor yields. In spite of this, the European Society of Cardiology recommends screening for atrial fibrillation, but this is not currently agreed with by the United Kingdom National Screening Committee, who didn't give a recommendation for atrial fibrillation screening when they last looked at this issue in 2019. So my question is, can we make atrial fibrillation screening effective? Because part of the problem with atrial fibrillation screening is that its clinical and cost effectiveness is limited by the low yield. Can we make it more effective by identifying a more circumscribed cohort at higher risk of developing atrial fibrillation? And to do this, obviously, a prediction model, which LIDA is well known for, could define a high risk group for a more systematic screening approach and hopefully identify a higher yield. The UK is particularly well suited for this sort of approach, because as we know, 98% of the UK population are registered in primary care with an electronic health record, and thus it is possible that we could scalably target individuals at high risk using a prediction model if it was embedded within this data source. So it could be clinically usable, it could automatically calculate risk, and therefore it could make efficient screening possible, as well as minimizing extra cost, because we'd just be using data that's already routinely collected in electronic health records. So obviously, when we were looking at this problem, as always, we just did the first thing we did was a systematic review and meta-analysis to assess what was already out there in terms of using community-based or primary care-based electronic health records to try to predict atrial fibrillation in the general population. And we found a number of models, about 9 or 10 models that fitted the bill, but we found a number of shortcomings. When we did our meta-analysis, we found that the discrimination performance, as measured by C statistics, so the ability to identify correctly higher risk versus lower risk individuals, was relatively moderate amongst most of the included models, only about 0.7 or so. We found that many were, the way that many had been constructed was at high risk bias, and also many of the models predicted atrial fibrillation risk over a 5 or 10-year horizon. But as a clinician, when I'm thinking about that, that's less useful to me when I'm trying to decide who I should be investigating for atrial fibrillation or who I should be screening for atrial fibrillation. What I'm more interested in is who's going to develop atrial fibrillation in the next few months, in the next year or so, because those are people who are more likely to get a high yield from investigation. And also, many of the algorithms we found, whether or not they were powerful, could actually only be applied to a minority of the population in routinely collected records because they've been developed with variables that are often missing in routinely collected data. So, for example, the CHARGE-F algorithm, which is a well-known algorithm developed in the US, because it requires a complete dataset for height, weight, blood pressure, etc., could only be applied when it's actually been applied in routinely collected records to about 17% of the population, because the majority of individuals, especially individuals from lower socioeconomic groups and ethnic minorities, tend not to have a complete data set within the last year for this sort of information. And the Pulse AI algorithm, an artificial intelligence machine learning algorithm, could only be applied to 35% of the population, because again, it requires certain blood tests and observations that are often not available in routine records. So this is a big problem from my point of view. If you can't scale your prediction model across the population within this data source, it's not going to be able to successfully target atrial fibrillation screening or inform clinicians. Also, what's also important when one considers implementation across a nation is whether your prediction performance is equally good in both sexes and across different ethnic groups, to ensure that if one applied an algorithm, it would actually be fair in how it performed across different groups in the population. But that was often not actually reviewed by most of these algorithms. We were very fortunate to receive research development funding from the university, and with that we convened a scientific advisory board to try to make sure that as we developed this model, we were going to do it to the most clinically useful. So we convened a group that included the former National Cardiovascular Disease Prevention Lead, primary care EHR providers, because we thought they were important stakeholders to have on board straight away, because fundamentally this is where we were looking to put this algorithm when it was fully developed. And of course, we used representatives from the regulatory bodies, from NICE in terms of who would be recommending this algorithm, and Public Health England, because they're the ones who recommend screening or did recommend screening before they were subsumed within NHS England. And of course, we also wanted to involve stakeholders who are clinicians, cardiologists and primary care healthcare professionals who would be actually using this algorithm or dealing with the consequences of its use. And of course, patient and public involvement groups, which we formed our own patient and public involvement group, as well as using the AF Association and Arrhythmia Alliance, who are a well-known multinational group. And some of the feedback we got right off the bat of this project was there's definitely a desire in primary care for some sort of model to help them identify people who are at high risk of atrial fibrillation so they can target diagnostics. The EHR providers were very clear that there's only certain things they can implement. So they can't implement certain types of machine learning, things like deep neural networks. They didn't feel they had the structures within their systems to be able to do that. And they also recommended that rather than developing some sort of live learning algorithm, from a regulatory point of view and from a governance point of view, they prefer a fixed algorithm, i.e. these are the variables and these are the coefficients between those variables. And also they reinforced the issue that of the importance of being mindful that when one is implementing the algorithm, the data that is available is generally much poorer than the data that's available within well circumscribed and well quality controlled research databases. So they wanted us to keep that in mind when we developed our model. So what did we do? So in our systematic review and meta-analysis, we found that traditional regression techniques for prediction modeling, so multivariable logistic regression models were common, generally had moderate discrimination problems, but of course they are easy to interpret and relatively easy to apply. Of machine learning algorithms that had been attempted, random forests were the most commonly used and tended to have relatively robust performance across multiple primary care EHR databases. So we set about to try to develop an accurate prediction model for short-term atrial fibrillation that would be scalable. So to do that, to make an accurate prediction model, we modeled both a multivariable logistic regression model, but we also modeled a random forest classifier. And to make it relevant, clinically relevant, we did a short prediction window, so only 6-month atrial fibrillation risk, so it's immediately relevant to clinician. And we wanted to make it implementable at scale. So we were very fortunate that we had access to a CPRT Gold dataset for this purpose, which is obviously large, over 2 million individuals, and was representative of the UK population in terms of age, sex, ethnicity, which of course was important to us to make sure that what we were developing would be implementable at scale. And also, we deliberately restricted the variables that we would use to age, sex, comorbidities, and ethnicity, because we knew that these were variables that would be routinely available with high fidelity. But of course, accepting certain things. One is, just because somebody doesn't have a diagnosis noted in their electronic health record does not mean they don't have it. It just means the clinician hasn't at any point coded it. But we accepted that that's a limitation. We treated it as a positive recording database. That is, if somebody has the diagnosis coded, they have that diagnosis. If they don't have that diagnosis coded, we presume they don't. And we included ethnicity because our feedback from the Scientific Advisory Board was that there is current efforts to effectively make sure that ethnicity is well characterised across primary and secondary care. And if data is not available in primary care, it's now being effectively retrofitted from secondary care to ensure that we have good coverage of that data across the population, partly as a response to the inequalities that were shown during the COVID pandemic. Of course, not everyone has ethnicity in their records, and thus we included ethnicity unrecorded or unknown as a variable, accepting that that's actually its missingness is informative in its own way. And then we used a user index to identify what would be the optimal cutoff to define higher risk versus lower risk using sensitivity and specificity. We evaluated performance in our holdout testing dataset, having trained the algorithm in 80% of the data, the training dataset, over bootstrap validation with 200 samples. And then we, of course, wanted to check its performance against other well-known algorithms. So the CHADS-VAS score is routinely used, one of the few prediction models that's routinely used in clinical practice of cardiology for prediction of stroke risk in atrial fibrillation, but it's often being used for atrial fibrillation prediction itself. And because it only uses age and comorbidities, it's scalable in electronic health records. And the CHESS score was originally developed in Asian populations for predicting incident atrial fibrillation, but has been validated in Europe as well. And again, just uses comorbidities and age, and therefore it is possible to scale this across EHRs. So we wanted to test this algorithm, which was designed to be scalable, against other scores that are also scalable. As I said at the start, though, we weren't just interested in predicting atrial fibrillation. We were also interested in the idea that atrial fibrillation in many ways is a marker of ill health, a marker of multiple comorbidity, and a marker of shared pathophysiological pathways that extend across vascular, arrhythmia, and renal beds and metabolic beds. And therefore, we want to check not just outcomes for prediction of instant atrial fibrillation, but amongst the higher risk population, we wanted to assess for the risk of other cardiovascular outcomes, heart failure, heart attacks, stroke, valvular heart disease, renal outcomes, so the new onset chronic kidney disease, as well as diabetes, and of course death. So in terms of the results, in terms of prediction performance, so these are area under the receiver operating characteristic curves, and find F is the red curve here. The multivariable logistic regression model we made is the blue curve, and the two models I mentioned before are these sort of grey curves. And fundamentally, what you can see is, as everyone will be aware of with area under the receiver operator characteristic curves, that the performance of find F is superior here, and is demarcated here with a higher number, so 0.824 compared to the other algorithms, which was slightly lower performance. Importantly, though, we also assessed performance across different subgroups, so across both men and women and across different ethnic groups. So what we generally found was the prediction performance is good, equal between men and women, and that's important because we found that the CHADS-VAS algorithm performed much better in men than in women, and was also showed relatively equivalent performance across different ethnic groups. And generally speaking, having a discrimination performance about 0.8 is not bad in each ethnic group. Of course, we have to accept the confidence intervals are very large for some of these groups, because obviously the actual prevalence of the population of a non-white ethnicity is still relatively low across the whole population, different between the country, the rural settings and the city settings. We didn't just stick at kind of discrimination performance per se. We also looked at other metrics of discrimination calibration, but we also want to look at clinical utility. So how actually useful would this be to implement in real life on a theoretical level? So first of all, comparing to other algorithms, we found that across the 2 million records, the algorithm could be applied to every single record. And that fitted our mandate of making this scalable and was better than many other algorithms we checked. And also we found that it had not just better discrimination performance, but favourable reclassification. So it more commonly classified individuals correctly into high or low risk than the CHANS-VASC and CHEST algorithms. And when we looked at the decision curve analysis, so would there be a benefit from using this algorithm across a threshold of probabilities of its use, we found that the benefit you get from FindEF would be higher than if you used the CHANS-VASC algorithm or the CHEST algorithm to improve your decision making and target diagnostics. So in short, the data suggested that compared to previously developed algorithms, FindEF was more highly accurate, was importantly scalable across UK primary care health records, gave a short-term clinically relevant prediction window, and importantly from our point of view, had robust performance in men and women and across ethnic groups. We also want to know about not just the short-term prediction, but if we're predicting people to have high risk of atrial fibrillation, does this translate not just into short-term risk, but also into long-term risk? And so when we constructed Kaplan-Meier curves and cumulative incidence rates for over the course of the next 10 years, we found that if you divided our group between the higher risk group and the lower risk group, we found that over the course of the next 10 years, a large proportion of these higher risk patients are being diagnosed with atrial fibrillation, but not just being diagnosed with atrial fibrillation, they're often being diagnosed with stroke and transient ischemic attack. So what we're interested in is not just picking up atrial fibrillation, but picking up atrial fibrillation that is clinically meaningful to treat. So our higher risk group seemed to be not just at risk of atrial fibrillation, but at risk of the consequence of atrial fibrillation, and to have those comorbidities and make them high risk of both of these conditions. So the hazard ratio was at least 8-fold higher for the high risk group than the lower risk group. And as I said before, we were interested to know, is atrial fibrillation a marker of general ill health? I.e., if you are at risk of atrial fibrillation, so if you have the age profile and comorbidity profile of people who get atrial fibrillation, but you haven't got atrial fibrillation at this moment in time, are you at risk of a number of other outcomes that we know is common in this group? And what we found was that if you compared the higher risk group here, and the blue line to the lower risk group here, generally speaking, across multiple cardiovascular, renal, and metabolic outcomes, as well as death, you had a higher risk of all of these outcomes over the next 10 years in the high risk group versus the lower risk group. And so when we compared it, we found there was a higher cumulative incidence, an increased hazard ratio, and a shorter median time to event for each of the pre-specified outcomes, with particularly strong hazard for things like heart failure, aortic stenosis, and stroke, as well as death. As you saw, between 25 and 30% of the high risk group die within 10 years. So it is a truly high risk group, not just from a cardiovascular point of view, from a general ill health point of view. And so when we looked at the higher risk cohort, which made up 19% of the cohort versus lower risk cohort, or 81% of the cohort, we found that this 19% of individuals made up 70% of heart failure cases, 65% of aortic stenosis cases, and 71% of cardiovascular deaths, and 75% of cardiovascular and cerebrovascular deaths over the next 10 years. So they're a genuinely high risk group. And then actually, I haven't got the figures in this presentation, but when we then did some sensitivity analyses where we adjusted for age, the presence of any of the other pre-specified outcomes at baseline, sex, ethnicity, we found that higher atrial fibrillation risk, even when you take out all of those important predictors, is still predictive of all of these outcomes by the nature of about 64% increased risk of heart failure, 53% increased risk of aortic stenosis, and 26% increased risk of death. So it's not just that these people are older, more comorbid, but the actual pathophysiological manifestation is likely what we're picking up in this data phenotype of higher atrial fibrillation risk. So our conclusion from the data is that FindEF is applicable in national EHR data and can accurately predict short-term atrial fibrillation, which may make it more able to efficiently target diagnostics of atrial fibrillation, but that short-term atrial fibrillation risk portends longer-term occurrence of atrial fibrillation, other cardiorenal and metabolic diseases, and death, and that this high-risk subpopulation may not just merit early access to AF diagnostics, but also programs to try to improve their longer-term outcomes across a wider spectrum of diseases. Of course, there are a number of limitations with this type of analysis. We've used retrospective, routinely collected data, and by definition, I told you that we think a lot of atrial fibrillation is undiagnosed in routine care, so the actual instant AF cases we picked up are probably underestimated. We developed this to be used in the UK, but we want to understand now how well it will employ in other external geographies. So we're doing validation work in Israel and Latin America, and so in both resource-rich and resource-light countries. And though we could tell that people getting heart failure, aortic stenosis, and valvular heart disease, based on the data we had, we couldn't tell necessarily the phenotype or the severity of those conditions. Nonetheless, these are both chronic, progressive, morbid conditions. So I think it's relevant that if someone's being coded with that diagnosis in clinical records, it's likely an important diagnosis. And of course, it may be that the data phenotype of atrial fibrillation risk may be associated with diseases outside of those we investigated. But we decided here to pre-specify some outcomes that we knew had a biological relationship and that we knew were potentially clinically actionable. So just very briefly, we've taken you through the fact that atrial fibrillation is common. We've taken you through our meta-analysis results, how we went about this, and what our results were when we looked at the prediction performance and clinical utility of FIND-IF. And I'm just going to very briefly talk about what we're now doing. So that's the prospective clinical validation. So our plan is that actually what we want FIND-IF to be is to be part of an actual pathway within the NHS, an end-to-end digital pathway to try to make atrial fibrillation detectable early and managed easily in a patient-centric way. So we want to use FIND-IF to identify people at higher risk of undiagnosed AF using their routine collected data, and then we want to make sure that individuals at high risk of AF get the diagnostics delivered to them in a way that is easy for them to integrate with. So we want to leverage new technology, make prediction more personalised, and then make the diagnostic pathway within the NHS more patient-centred, and try to overcome some health inequities in access to care, and try and shift the whole pathway of NHS care more towards the preventative spectrum rather than just dealing with end organ disease. So we're very fortunate that the British Heart Foundation and Leeds Hospitals Charities have given us some funding to conduct a prospective clinical validation. So this will be a interventional, single-arm, open-label, non-randomised study. And what we're doing is we're implementing FIND-IF in System 1, one of the primary care electronic health record system providers that cover about, I think, 2,000 GPs across the country. And we're taking individuals who would be eligible for anticoagulation if they were diagnosed with atrial fibrillation, but don't currently have atrial fibrillation and aren't on a palliative care register. And we're risk stratifying them with the FIND-IF algorithm. We're taking people who are both higher risk and low risk, so across a broad spectrum of AF risk, and we're inviting them through a multimodal invitation to undergo ECG monitoring at home. And the idea behind that is that previous AF screen studies have asked people to come in to research clinics to be consented and to do their diagnostics, but actually we found that that limited participation amongst minority ethnicities and people with greater comorbidity burdens. So the whole idea is to have a patient-centric remote pathway. And the idea between inviting both high risk and low risk people is to actually prove that in addition to just providing diagnostics, the actual risk itself in a prospective validation is meaningful and improves detection. And then people who we detect with atrial fibrillation, we're going to provide primary care with that diagnosis, and they will manage them down their routine pathways. We're also conducting a bit of a phenotyping clinic, a multimodal characterization of individuals at higher risk. So they're being offered the opportunity to come and see us in a research clinic. And the idea behind there is try and understand the data phenotype of atrial fibrillation. I want to understand clinically what those individuals look like, and we want to provide them both with a clinical review, an understanding of their biomarkers and their risks from that point of view, as well as some baseline imaging investigations to understand the burden of undiagnosed and untreated comorbidities and risk factors for that population. So we're going to take 1,955 people through this pathway, one-to-one enrolment between higher and lower risk individuals. And the primary outcome will really be to understand if we can diagnose more cases in the higher risk group than the lower risk group through this through this ECG monitoring pathway, i.e., what's the incremental benefit of AF risk to already providing extra diagnostic device. And we'll also do some stuff about how the model performs in a prospective validation versus a retrospective data set. And we'll also just make sure that the individuals who we diagnose with atrial fibrillation actually end up getting treated, to understand that there's no point detecting people unless the management changes and they get better clinical outcomes. And of course, I mentioned the multimodal characterization to better phenotype and try and understand mechanistically, does the data phenotype of atrial fibrillation risk characterize in certain comorbidities or certain echocardiographic or cardiac MRI features that indicate atrial fibrillation risk or risk of other outcomes. We've also been mindful that if we want this to be used, we have to go through all the regulatory approvals for requirement for use in the NHS. So we were very fortunate to get NIHR Eye for Eye fast funding, which we used to procure the services of a regulatory consultant to allow us to get FindDF certified as a Class 1 medical device, because this is now a new requirement of the Medical Device Directive that any software that's going to inform clinical decisions needs to be classified as a medical device. We've also gone through the digital technology assessment criteria to gain acceptance onto the NHS digital health technology library in the NHS. And we've also completed the DCB 0129 process, which is all about clinical safety and understanding the clinical risk of using your software and understanding how you mitigate that risk. So that's been a piece of work in itself, and it's actually really opened our eyes into actually producing a device that may be useful in clinical practice and actually reduce the risk for EHR providers in taking on our algorithm into their systems. To get to this point, we've obviously lent on the advice of our scientific advisor. We've also done the rounds amongst national and regional stakeholders to receive the approval of both national bodies, regional bodies, and also on the ground get primary care partners involved in this process. We're really fortunate that about 70 practices across the UK have signed up to try to use the algorithm and provide us data on if it's improving care, and as we try to expand the initial pilot implementation into a bigger scientific observational study. So in summary, we've developed a FindDF algorithm which we think can identify people at higher risk of atrial fibrillation. It leverages information in routine collected record to accurately and scalably provide AF risk prediction. And now we're moving on to clinical implementation and international external validation to try to scientifically prove whether the use of this algorithm will actually improve outcomes. And that's been, as many of you all know, a big problem in many previous prediction models, that they're developed, but they're not actually implemented to see if they improve care. And ideally, we want to improve early AF detection and prevent stroke. Our plans are to integrate FindDF in multiple EHR platforms in the UK to provide this service to primary care healthcare professionals. As I said, we want to characterize what this at risk of AF data phenotype actually is in terms of the mechanistics of that and the pathophysiological pathways. And we're working with our commercialization team to realize opportunities both in the UK and abroad. So thanks very much for listening. I'm not sure if I've run over significantly. I'm not obviously happy to answer any questions. Also happy to answer any questions offline if that's preferable.
Thanks, Ramesh. We've got 15 minutes for questions, so perfectly on time. I think we've got one from David.
Yes, I'm wondering what the false positive rate is, because you can't tell that from the area under the curve, and that's rather important, isn't it? And how it compares with simpler methods as well, how the false positive rate compares with simpler methods. And I guess false positives don't matter too much if they're just going to be put on anticoagulants and bisoprolol, but if you're going to go for ablation or something, they matter rather a lot.
Yep. Yeah, I completely agree. Really important point. So a part of I didn't go into all the outcomes that we're investigating in the prospective clinical validation, but as you say, when you say false positive, I presume you mean people who are identified at high risk of atrial fibrillation but don't actually have atrial fibrillation when you investigate them. Is that right?
Yeah, that's right. Yes.
Yeah. So undoubtedly, I don't go into a great deal about false positives based on routinely collected retrospective data, because we know that many of those people probably do have atrial fibrillation but haven't been diagnosed during routine pathways. We will be looking at the sensitivity, specificity, positive predictive value, negative predictive value, false positive, false negative rate in the prospective validation. So when people are actually undergoing ECG monitoring, and so we have a good understanding of whether there was true atrial fibrillation there or not, we'll be able to better characterize whether there's what the false positive rate is there on its actual implementation. In terms of, as I say, the clinical consequence of false positive is an interesting point. So if someone's defined as higher risk of atrial fibrillation, but doesn't have atrial fibrillation now, what does that mean? So at the moment, our intervention is to provide somebody with a non-invasive ECG monitor. So the one we're using in this study is one of these Xenical devices. I don't know if you can see that on, if it's kind of blurred out, but it's effectively a handheld little monitor. So it's not a significant intervention. And so there's obviously the risk that if somebody is told they're high risk of atrial fibrillation, undergoes a monitor, and then doesn't have atrial fibrillation, you can cause health anxiety, but also you can provide false reassurance. You told me you were high risk, but you tested me and I didn't have atrial fibrillation, which I think we've done some qualitative work with our PPI group, as well as leveraging some of the research we've done in the past. And our understanding is that previous patient groups that have been discussed this with have said, we'd rather be tested than not be tested. We would rather know we were at risk than not know we were at risk, because then, as I've said, even if you don't have atrial fibrillation in the next 6 months, we've shown that it's very likely that atrial fibrillation risk in the short term also translates to atrial fibrillation risk in the long term. So actually, it might act as an opportunity to work with primary care healthcare professionals to try to mitigate certain risk factors, try to reduce one's risk of atrial fibrillation in the long term. And also being aware of one's risk might mean that if one later gets certain symptoms, palpitations, breathlessness, chest pain, tiredness, etc., that may be related to fibrillation, it might increase the possibility that an individual would actually seek healthcare services rather than limiting their involvement in healthcare services, and therefore might increase the opportunity of being detected in routine care. But I completely agree, the false positive rate is really important. The intervention for many of these patients may not extend beyond oral anticoagulation if they had a diagnosis, because obviously we're particularly targeting individuals who are minimally symptomatic or asymptomatic, and and likely have paroxysmal rather than persistent atrial fibrillation. And so the evidence base for being more interventional than oral anticoagulation in that cohort is less well evidence-based at this moment. So I wouldn't be thinking that a large number of the individuals that we detect would have an indication for catheter ablation. But of course, that's to be scientifically proven when we do this validation.
Thank you.
I hope that answers your question.
Great, thank you. I think we've got Amanda next with another question.
Thank you. Really interesting talk, Ramesh, and really clearly explained. Thank you very much. For those that don't know me, I'm Amanda Farron, and I'm Professor of Clinical Trials and Trials Unit here at Leeds, and a statistician by training. So my question relates more to some of the sort of technical stuff of the algorithm and how it was derived. And obviously, as a statistician, I'm much more familiar with the sort of typical regression techniques. Could you give a little bit more detail about how the machine learning algorithm differs, so that we can maybe understand how that then resulted in a better performing outcome at the algorithm at the end of the day?
No, of course, yeah, more than happy to. Thank you for the question, Professor Farron. So, as you said, I'm personally a believer it's always best to use the simplest, most interpretable option first. And literacy regression models where you have your variables, you have your coefficients, you understand exactly how they interact and you can show individuals why they're high risk or why they're risk based on certain variables, is, I believe, the best approach if it gives you the best prediction performance. In this case, we use a random forest model, so that is effectively it's a supervised algorithm, so therefore we have we're using labeled data, AF, no AF, and we gave it a series of variables, age, sex, and the comorbidities I mentioned before, and effectively it has a series of decision trees which have nodes on them, which are effectively breaking points where the algorithm's basically just randomly moving people from one way to the other at each node to decide whether they're high risk or low risk. And with the random forest, by effectively bagging multiple of these trees together, you then get what the prediction would be for each tree for each individual, and then they're summed or averaged to get what that prediction would be for that individual. And that effectively allows for to a certain extent, allows for more non-linear interactions to be incorporated, which is probably why I think you get slightly better performance. The issue is that then it's not as interpretable. So we could use a Gini coefficient, so an understanding of the so what we could do there is, by looking at the different variables, we can work out by the Gini coefficient, so that's the decrease in the Gini. So that's basically how important each variable has been over the course of all the predictions. And we could tell that age was the most important predictor, and heart failure was an important predictor, and ethnicity and sex were important predictors. We couldn't tell for each individual how those coefficients, how those variables interact. So by definition, I would define it as not interpretable, kind of opaque interpretability. So compared to a deep neural network, which, I know there's multiple ways that they're trying to make it more interpretable. It's fundamentally a black box. You just put the variables in, and they've gone through these neural networks, and they've made multiple layers, and they've made abstract representations, and then you've imposed a classifier on top of that. Here we've got a classifier on labeled data, but again, the way that those variables interact after we pre-specify what they are is completely a supervised machine learning. So it is done by the algorithm. We train the hyperparameters to using cross-validation to try to not to limit overfitting, but still it's at risk of that. And we did find in our multivariable logistic regression model and in our random forest model, interestingly, equally, that there was evidence of over prediction in the sort of mid-risk cohort between high. Now, actually, one might say that implies that there's over risk prediction there. My other query is actually potentially that's more an indicator that actually those individuals may have had atrial fibrillation but weren't diagnosed during routine care, because we mentioned about all the ways that those people have missed in current care. Was that in some way helpful to your question?
Yeah, no, it sort of certainly provides me with more understanding of how the technique is arriving at the eventual decision tool. I mean, it strikes me, it isn't something that you need to do now, but sort of more from a methodological question. There's other statistical techniques that potentially try to mimic some of those features in the data, the non-linear relationships and so on. That is a sort of spin-off project might be interesting to follow on, because I think what some people might take from this is that machine learning is better than statistical methods for deriving this prediction algorithm, and actually you've just taken two, and one maybe is more suited to the features of the data set, and actually a statistical method that is more suited to the features of the data set may have come up with a similar prediction rule, or a more efficient one, or a more effective one, or whatever. So just as a sort of holding the flag up for statisticians and statistical methods.
I completely agree, and also I to be fair, we were slightly biased in how we approached this, because the funding from the BHF was very specific that it wanted us to interrogate a machine learning model approach as well as statistical regression. So we were always going to do that. We did find that on the when we did our systematic review, when we looked at this is purely discrimination performance, because many reports only mention C statistic or area under the receiver operating characteristic curve. But some machine learning model would various ones, neural networks, naive Bayes, random forest, etc., would perform better than a multivariable distributed model for purely discrimination, about everything else. But actually, I think that if we're talking about implementation at scale and use in both resource-rich and resource-light environments, and outside of the huge longitudinal databases that you get in primary care records in the UK, that a traditional regression technique is a better approach, to be honest, in many cases. But yeah, so actually, simultaneously to this, we are developing a very parsimonious multivariable distribution model, because we want to test how that would work in alternative settings, ambulance settings, secondary care settings, where you don't necessarily have the richness of the data that we have here. But I completely agree. It's not. I'm not trying to say machine learning is better than non-machine learning. It's just one of the ways we approached it in this project.
Thanks very much.
Thanks, Ramesh. I think we've got another one from David. Probably got time for one last question.
Yes, I'm wondering if this stuff runs locally on your computer or if it's in the cloud. I'm asking because I discovered that ChatGPT costs $100,000 an hour, I think, to run, and it must produce immense amounts of global warming. It's not the primary problem, but
No, it's not. So at the moment, the way we've got it to work is that actually it's centrally run. It's centrally actioned by TPP. They have effectively an API, an application programming interface, that links between their data and sends the data through, or sends the kind of data stratified in a way that the algorithm can interpret it, and then sends it back to TPP. So effectively it runs as a widget within electronic health record. It doesn't work on an individual computer. It works within their system. As to what their carbon footprint is, or how much it costs, or how much their computing power is required to run the EHRs platforms, which are obviously huge central platforms, is probably significant, but I haven't looked into that, to be honest.
thank you.